Okay, hi everyone, and thank you for joining this meeting of the Australian Sensitive Data Interest Group. Today we're doing health data and learning about federated approaches for analysis of sensitive healthcare data sets from the OHDSI approach. Before we begin, I would like to do an acknowledgement of country by acknowledging the traditional owners of the lands on which we meet today. For me, that's the Whadjuk people. I pay my respect to elders past and present who have preserved the language, knowledge and culture of this place for tens of thousands of years. It is now the season Makuru, which is the coldest and wettest time of the year and the time when animals begin to pair up ahead of the breeding season. Indigenous data is often sensitive data. Historically, Indigenous data has been used in systematic oppression of Indigenous people at the hands of colonial and state powers in our country's history. I have been taking every opportunity to educate myself in cultural competency, including the challenges of learning the truth about Australian history since 1788 and the use of Indigenous data in the foundation of the modern Australian state and its institutions. As a result, I'm better prepared to work in partnership with Indigenous colleagues on the governance of their data, and I would like to encourage everyone here to learn about these matters too. So as you've probably seen, we are recording today's session. So if you don't want to appear in the recording, maybe turn off your video and microphone. And it will be shared through the Australian Sensitive Data Interest Group YouTube channel, and probably put a link to this on the relevant pages for the OHDSI project. Okay, also if you haven't been to an OHDSI meeting before, please feel free to join our mailing list. It doesn't have a huge amount of traffic, so you're not going to get a lot of spam. It's mostly just communications about upcoming meetings, recordings, and occasionally people share sensitive data related news. So yeah, feel free to join from the website and share that link with any of your colleagues who might be interested. Okay, so today Nicole Pratt from the University of South Australia and Roger Ward from the ARDC are going to be talking about the OHDSI project. So Nicole is a professor of biostatistics and pharmacoepidemiology with a strong track record in real-world evidence generation using large-scale health data sets. She's played a key role in shaping national conversations around the safe and secure use of healthcare data for medicine safety and health outcomes research. Nicole is a founding member of OHDSI and brings expertise in data governance, linked data analysis, and stakeholder engagement. Roger Ward is a strategic solutions architect at the ARDC, where he leads initiatives focused on research infrastructure and common data models in health. With a background in medical informatics and experience across government and health sectors, Roger works at the intersection of health data systems, interoperability, and federated research platforms. He's a founding member of ARDN and is actively involved in national and international efforts to harmonise the use of data for public good. Just before I hand over to Nicole, it would be great if you could hold on to your questions at the end or maybe just put them in the chat, and we'll have a discussion after the presentation has finished. So I will stop sharing and over to you, Nicole.
Thank you so much, Carly. I will start sharing my screen. Okay, just confirming you can see the screen?
Yes, we can. Thank you.
Perfect. Well, thank you so much for the invitation, Carly and the team, for presenting some of the work that I've been doing over the last 10 years at least on using sensitive data for healthcare evidence generation and decision making. So I'm going to give a bit of an overview of the OHDSI approach, and then my colleague Roger is going to talk a bit more in depth about the governance of this sort of approach and and what it means. And then we'll open up for some discussion. So get your questions ready. We'll have plenty of time for discussion. And first of all, I'd also like to acknowledge the traditional owners of the land on which I'm meeting and presenting to you today. It's the lands of the Kaurna people of the Adelaide Plains, and I pay my respects to elders past, present, and emerging. So let's get started. Oops. All right. So to set the scene, I'm going to take our mind back to 2020, a significant event in our history, of course. And I'm going to kind of set the scene with a bit of a story. And, you know, I used to love these stories when I was a kid, choose your own adventure stories. And this one in particular, you know, you can see the girl there on a unicorn fighting off the demons and the dragons. And it kind of reminded me of the story of how data played a huge role in COVID-19. So let's have a look at that. So if we cast our mind back to early March, the start of the pandemic, there are lots of news stories that came out at the time. A whole heap of different, you know, conspiracy theories and other questions about what made people more susceptible to COVID-19, who was most at risk, and so on. And this particular news story came out really early on, 13th of March, saying that medicines that people take for their high blood pressure could raise the risk of deadly coronavirus symptoms. And, you know, this was based on some data that was available at the time. And it really sent, you know, some people into a bit of panic, saying, oh no, these drugs that people take called ACE inhibitors or angiotensin receptor blockers may change the shape of someone's cells in a way that makes it easier for coronavirus to infect them and cause a more severe illness. So that was the thought at the time. And that really did send some, you know, doctors and patients into a little bit of concern. And that prompted the American College of Cardiology to actually publish a statement to say, look, don't, you know, we don't know much right now. Don't change patients, their healthcare. Don't change their treatments until we find out what's going on. And we urge additional research that can guide us to the optimal care for the millions of people that are taking these blood pressure medicines. So you can see that these claims often come out and people sort of change practice because of it without really understanding the quality of, you know, the data that's underpinning those concerns. So, of course, at that, researchers then went, oh, well, we need to understand whether blood pressure medicines actually do influence susceptibility to COVID-19 infection or poor outcomes of COVID-19. And of course, at that, researchers off we go, trying to understand, you know, this question, are these medicines really associated with an increased risk of COVID-19? So what happened? We have different data sources across the world, all in different formats, all in different structures, some identified, some not identified. And a researcher goes and looks at that data source, does their analysis, and found, well, patients on ACE inhibitors, a particular type of beta blocker, are at lower risk of death from COVID-19 compared to those not taking treatments. Another researcher looks at another different data set, this time a de-identified data set, and finds that patients on ACE inhibitors are at a higher risk of death from COVID-19 compared to those on different blood pressure medicines called calcium channel blockers. Now, another researcher goes to another different data set, this time in the elderly patients, and says, well, actually, we don't think that there's a difference in risk compared to people on different type of blood pressure medicine, ACE inhibitors. So you can see those different data sets produce different outcomes. Now, this could be for a whole heap of different reasons, and I've just listed a few here. The first is kind of data quality. Who knows what that data quality is like within each of those data sources? How did those researchers access that information? Was it direct access to identified information? Was it direct access to de-identified information? Or was it direct access to a subset of the data source, not the entire data set, but just the subset in the elderly patients. What approach did they use? How did they actually do the analysis? Was it the same? Was it different? And what about the results? How were they presented? In what format? How were they communicated? So you can see that there's a whole heap of different processes across, the world in how people would have gone about approaching this kind of study question. So this actually happened in real life, and a couple of months later, the first report was in March, but in June, the Daily Mail, the same news outlet, came out with this report saying, actually, whoops, we were wrong. Instead of the blood pressure medicines actually increasing the risk of COVID-19, there's actually a decrease. Okay, so you can see that depending on how you do the analysis, you get sort of these different results. And it was just in one small patient population in China. So is there a better way? Can we take a different path and choose our own adventure story? And we can. Instead of having these individual data sets in all their different formats, we can standardize those data sets into a common data model. And the common data model I'm going to be talking about today is the OMOP Common Data Model. There are lots of other common data models out there of various different types, but the OMOP Common Data Model is the one I've been, working with for the last couple of years. So the way it looks is we take our individual data sources and then we transfer them in those data sources into a common data model format. So that's a common format for storing the data, right? So it's the architecture of the database itself is standardized into a common format. What also happens is that the data within those data sources are translated to a common vocabulary. So this means that the individual components of the data themselves, so the codes that are used, are all translated to a common code. So a heart attack in Australia has got a particular ICD code, but that gets translated into a standard code, a SNOMED code that is used across the world, and everybody translates their own data into this common language. Now, the reason why that's important is that we can now start to do coordinated research across different data sets. We have the same architecture, we have the same language, and now we can use the same analytic techniques and the same analytic code to perform on those individual data sets without having to change it, make different decisions, have different analysts writing different sets of code, and so on. So we can standardize now our analytics, and then we can standardize our results. So the OHDSI OMOP Common Data Model is developed by an international collaborative group called OHDSI, Observational Health Data Sciences and Informatics. OHDSI is a really large international group of people who've kind of come together to improve health by empowering a community to generate the evidence that promotes better health decisions and better care. So really what that means is we're all getting together to try to generate the evidence that's needed across the world to answer specific questions in healthcare that can't otherwise be answered in things like clinical trials, for example. So here's just a map. Now, this was probably a year ago, this map. So it's probably distributed a lot more widely now. But right this minute, we've got about 12% of the world's population sitting somewhere in an OMOP database across the world. It's a huge collaboration. I can see down there, there's probably now nearly 500 data sources that are translated to the OMOP Common Data Model. There's also a breadth of types of data that have been translated as well. So you've got electronic health records, so things like hospital-based electronic health records, or general practice, electronic health records. There's registries. So, whoops, I don't know why that did that. Registries like, disease registries or patient registries that have been translated to the OMOP Common Data Model, and administrative claims data as well. So claims data that are used for, billing purposes, for example. So yeah, there's a lot of data out there that has all been translated to this particular architecture. So the actual OMOP Common Data Model itself looks a bit like this. This is a caricature of the actual, detailed Common Data Model. But what happens is it's a person-centric model. So we have a patient ID, de-identified patient ID, and all of the healthcare journey for that patient hangs off of that ID. So we have observations, we have visits, conditions, drug exposures, procedure occurrences and devices and so on. So all the elements of healthcare have a place to go in this OMOP Common Data Model. And you can see here that there's a whole heap of common vocabularies as well. So general vocabularies like age and gender, for example, other vocabularies for drugs and for procedures and so on. And for those of you who haven't seen this before, you'll see this all the time when you look at an OMOP or an OHDSI presentation, is this concept of an international travel adapter. So the CDM is like an international travel adapter. You have data in your own format, you just need the plug for it to play with other data sets internationally. So because you're the OHDSI and you're interested in security, I just wanted to make the point that OHDSI works within the same environment and the same secure infrastructure as data right now. So the OMOP CDM is really just a translation of the source data within the same secure infrastructure that exists in the data custodian's control. So really it's just another way of storing the information within the structure that already exists. So what happens, we have your source data, we do this ETL translation to the OMOP Common Data Model. ETL stands for extract, transform and load. So we now have the data in a de-identified form in a different structure, which we can do standard analytics on it. So you can think about it as, just another storage facility that researchers can then access or write code against within the firewall. So the analysis is performed behind the firewall. The analysis results are really the only thing that ever gets shared externally. So it's just summary statistics and results. The beauty of that approach is that it can scale up, right? Once we have our data in an OMOP CDM, we can then write particular code for a single study or for a single question. And that can be executed against that data set and the results generated. But what it could also do is really scale up that analysis to do a whole heap of questions at once. Once you have the structure of an analysis, you can then just translate different outcomes, but use the same approach, for example, or change the exposures and look at the same outcome. So you can start to sort of build up analyses at a much more sort of large scale analytic format. So I've just highlighted here the only time in this process that researchers really need access to data is in the execution stage. So the writing of the protocol and developing code does not sort of require any access to data at all. It can be done completely outside of the cloud or wherever the data is stored, because we know what the format of the data looks like we can write all the code and do all of that sort of analysis sort of outside of the system. The other important thing is that the analyst can also just send in the analytic code, and that can be executed by people within the data custodian's firewall. So analysts don't even need to see the data; they just need to write code against the standard structure. So let's go back to our COVID-19 example and see how this kind of works in real life. So back in March 2020, the OHDSI collaboration was meant to be holding a conference in Oxford. And instead of that, obviously, because the world was locked down, we did an online study-a-thon where we got together and tried to answer questions that were important in this COVID-19 sort of era. And one of those questions was the one that I just talked about. Do blood pressure medicines increase the risk of COVID-19 or poor outcomes if you do get the disease? So we all worked together to answer that specific question using this distributed network analysis approach. And the reason we could do this, and we could do this really quickly, is because there were already data sets across the world that were translated to the OMOP Common Data Model. And those data sets had information about COVID-19 in them as well that could be quickly translated or translated into the OMOP CDM. So there's a data set in New York, another one in Spain, and the VA in America. So we were able to write the code externally all together, work out the protocol, how we were going to approach the study, generate that analytic, package, and then submit that to the data custodians for them to run against their data set and provide back the results. And these are the results we get, just the results, the estimates, the summary estimates. And we were able to really quickly identify that there was not an increased risk of COVID-19 with these blood pressure medicines compared to other blood pressure medicines. And that was all done really quickly. We had results posted in medRxiv by June of that year, and the full paper published a little bit later. It takes a bit longer to publish full papers, of course, than it does to take the analysis, to do the analysis. So this was a really important piece of work because we had the data in a structure that was available for really rapid analysis. We had the governance in place to be able to do this kind of research with those data custodians. And the only thing that was transferred from the data custodians were the summary data elements that could be collated to really answer this critical question. So really quickly, here's another example of some work that was done during the COVID-19 era. And this is really an important piece of work that just provides, very simply, the background rates of adverse events of special interest for the COVID-19 vaccine. And I'm really just showing you this to highlight the point that, having a federated network of data assets allows us to do these really simple pieces of work, but at a huge scale. And it helps us to understand, variation of outcomes across countries, variations of outcomes across different subgroups of the population. And all of this is just through one analytic code against, lots of different data sets. So you can see here on the right, each of these different colors is a different data set. And you can really start to see variations in outcomes. So where are we at in Australia with this kind of approach? The ARDC has been, sort of instrumental in sort of helping OHDSI and OMOP become part of what Australia is doing in terms of healthcare data analysis. So there was a project run by the ARDC maybe 3 or 4 years ago now, which was called the EMR to OMOP project. And what that project did was it took some data that were in Queensland in a hospital-based EMR and did a pilot program of how that data would be translated to the OMOP CDM. That was a really successful project and run by Roger, and he might talk a little bit more about that. But that has now sort of led to another project that we're hoping to get off the ground with the ARDC called the Australian Health Data Evidence Network. So this will be a program of work across Australia to try to sort of standardise the translation of hospital-based EMR data sets for, research and distributed research across the nation. I won't go through this, but this is just to show you the types of things that we're hoping Aidan will develop. So there'll be, translation of data from the EMR data sets across the states, facilitate research against those different data sets, build capacity in doing the translation as well as, doing the analytics, and then building federated services. So building analytic tools that will allow research to be sort of upscaled here in Australia for anybody who has data in the OMOP Common Data Model. So I'm going to leave it there. I've gone a little bit over time. Sorry, Roger, and hand over to you to talk a bit more about the governance of this approach.
Thanks, Nicole. If you could stop sharing.
I have. Yep.
Excellent. Just give me 1 sec while I share my slides. Okay, can everybody see that?
Yep.
Excellent. Okay, so my name's Roger Ward. I'm a solutions architect at the ARDC, and I'm just going to talk to you about the OMOP CDM and importantly governance, because it's very sensitive data we're working with, so governance is central to what we do. I'd just like to acknowledge, do an acknowledgement of country. I acknowledge the traditional owners of the land on which I speak from today, for Wurundjeri people of the Kulin Nation, and recognise their continuing connection to land, waters and culture. Okay, the OMOP CDM and governance. By its nature, the data we're working with is extremely sensitive. It's people's healthcare record. So it's incumbent on us to do this ethically and with governance. Health information is extremely sensitive and it's governed by Australian law, both federal and state law, and we've got to comply with those laws. So health services face strict data sharing rules and we've got to work within those rules. Researchers may access data under certain conditions. Now, it's fair to say at the moment, because of the fragmented nature of the data across Australia, it's in different EMR systems around the country, and also governance restrictions, it's quite difficult to access this data at the moment. But it's imperative we do access it for the type of examples that Nicole's just talked about, because it's a goldmine of information that can actually help with clinical care and research. So it's very important that we get the governance right so we can access this data ethically. So we call this use of EMR data secondary use of the data. So its primary use was to do patient care, but it has a secondary use, and that's important in research. So the OMOP CDM standardizes EMR data for easier secondary use. That's what Nicole's talked about, that example of the international travel adapter. So we're standardizing it so we can use it for secondary use. And a key principle here is the OMOP conversion occurs under existing governance structures. So we're not reinventing governance. All the hospitals and health authorities have existing governance processes. And we've got to work with those existing governance processes and where necessary, adapt those governance processes. So CDM standardization and security. Now, a common EMR system that's used in Australia is a system called Cerner. It's an American system, and it's highly complex. It has over 5,500 tables in the database to store patient records. So it's very difficult to get meaningful research out of. So what the OMOP CDM does, it pulls out the good bits, the bits we're interested in, things like conditions, medications, how long someone was in hospital. And it puts them into the OMOP tables, and we call them the clinical tables in OMOP. And it uses standardized vocabularies. So we leverage existing vocabularies like SNOMED for conditions, LOINC for observations, and RxNorm for drugs. And importantly, the source data, as Nicole said, stays within the jurisdiction of the hospital or the healthcare network. We don't move it, it stays there. And the great thing about this is we can leverage the existing data security within hospitals. So all the time and effort that's gone into cybersecurity in health authorities and hospitals applies to the OMOP data as well, because that's where it's being stored. Just some words about privacy in OMOP. So as Nicole said, we de-identify the data. We can either give people a code number, or we can pseudo-anonymize the data where we give someone a fictitious name. So there are ways of de-identifying the data. As I said, we use local firewalls to protect patient-level data. And importantly, as Nicole said, only aggregated, de-identified data is shared at the end of the process. So we're pretty happy with the security here, and it reassures the data custodians as well that OMOP is a secure way of carrying out research. So it's important we integrate with existing governance frameworks. So a key principle here is that data custodians maintain primary governance responsibility. So the people who have control of the data currently also control the OMOP data. OMOP operates under the custodian's existing access protocols. We align with key principles, so fair, findable, accessible, interoperable and reusable, care, collective benefits, authority, responsibility and ethics, and importantly, from a security perspective, the five safes framework. So safe people. Do we know who's accessing the data? Are they researchers who are trained to handle data appropriately? Are they named on ethics, human ethics of the project? Safe projects. Does the project have human ethics approval from a local human ethics board to proceed? Safe settings, that's all about firewalls and where the data is held in the virtual servers in the hospital. Safe data, is it de-identified? Have we taken steps to remove identifying information from the data? And safe outputs, that's all about aggregated data only leaving the trusted research area. So only the results are shared. Just to recognise there are some different use cases. So the hospitals can use the OMOP data for operational reporting. So they can use it for quality assurance and they can have insights on their own data. And that probably has a lower threshold of governance because hospitals can routinely do this already. They can look at what they're doing from their EMR record and try and improve things. And they can also use the OMOP data for that. But if it's going to be used for research, there is a higher bar, and we've got to have local human ethics approval within the hospital, and we've got to align with the local governance procedures in the hospitals. It may need some amendments for the OMOP Common Data Model, but wherever we can, we just line up with what they're already doing in the hospitals. And we take the opportunity to educate the local human ethics committees about OMOP and how it's a safer form of research. So access is limited to approved researchers, as I said. That's all about safe people, and outputs and storage require HREC approval. That's safe data at the end. And just a word about consent. We typically use the waiver of consent for minimal risk projects with stakeholder support. The NHMRC has a policy on waiver of consent, and I encourage you to read their policy if you're interested in this aspect of the study. Okay, some benefits and challenges of the OMOP CDM. Benefits, it's a secure, standardized analysis framework. I think it's got easier governance across organizations, and certainly the ARDC is trying to help with this. So Nicole mentioned the forthcoming AIDEN program that the ARDC is sponsoring. One of the work packages that's going to be in that program is a work package on governance. And part of that is we're trying to standardize how governance can be done across the different jurisdictions in Australia. So using best practice from existing governance procedures and educating people about how governance can be adapted for OMOP. Other benefits, it enables reproducible real-world data research, as Nicole said, with the COVID example. And importantly, it's got strong community support. It's prevalent in the US, Europe, and the Asia Pacific. So there's strong community support for OMOP. We're also talking with state and federal governments about this, and they're very interested in the OMOP Common Data Model. Challenges, there's varied institutional governance, which makes alignment complex, but hopefully we can help with that. Extensions may be needed for specialist areas. So for instance, the oncologists used to complain that OMOP wasn't granular enough for them. But the OMOP community responded to that, and they created something called the oncology extension, and that accommodates the oncology data. And they've done something very similar for medical imaging and pregnancy data. There's also a gap between hospital and primary care, and it's important. And the reason that's important, you've got to follow the patient journey from general practice, hospital to discharge, but linking could help with that. So linking is possible with the common data model. So just in conclusion, the OMOP CDM enhances EMR utility while respecting governance. There are a couple of resources that point you to. Last year, I wrote a paper with Dr. Christine Hallinan, and Nicole was on this paper as well, Seamless EMR Data Access, Integrated Governance, Digital Health, and the OMOP CDM, a nice catchy title. And that's in BMJ Healthcare Informatics, and that was published last year. And then again last year, I wrote with a panel of editors the ARDC Medical Research Data Integration Framework. Again, Nicole was on that framework authorship group. Now, I think we've got around 20 minutes for questions, so I'll hand back to Nicole now, who will MC the questions. Thanks, Nicole.
That was great. Thank you, Roger. And I can see there's lots of questions happening in the chat. So, I mean, we have time for people to ask their questions. So should we just go through those, Carly, or